All right, I just called Tim. He is about to join. So as we get going here, first of all, congratulations to those of you who have made it this far. We are, I believe this is our sixth or seventh APM meeting. Raise your hand if you've been to every single APM meeting and have been with us the whole way. All right, see a couple of hands. Congratulations. Thanks so much to everybody for your contributions to this group. I know some of you have also been on the other work groups as well, so really appreciate everybody sticking with the work. As I get started here, let me just share the screen so we can take a quick look at the agenda for today. Work group goals have been the same throughout our work in this group. We started all the way back in June, if you can believe that. Reviewing approaches to APM and behavioral health, both within the state and outside. And ultimately making some recommendations to the Behavioral Health Plan Advisory Board and 12 State Department commissioners. We have, hopefully you received in your inbox drafts of the work group report, which we will focus our attention on today. And that's going to be the majority of our discussion. We will leave time at the end, though, to talk about wrap up and final thoughts. Although this will be the last meeting of this particular work group, we do have plans for continuing some work group activity just by way of following up on and checking in on recommendations from all the work groups that have taken place over the last 6 months. So with that, I'll turn it over to Tim for some welcome and introductions, and then we'll get started.
So good morning, everybody. Appreciate everybody's joining. Our apologies. We did kind of mention that we would hear from Bill Halsey today, and he's unable to make it. So I think we will wrap up the work group. We'd ask you to just to remind you that our goal was not to put forth a quote unquote Connecticut APM model, but that we were really to review kind of the underlying components and principles of the APM models, and also to hear from a couple of different states. And so the second part of the work group was to look at and consider the measurement based care in general and different potential platforms, just as by way of exposure and kind of, again, some basic principles. So that's what the report is really focused on, and we'd like your feedback on that as we finalize that draft. We're hoping to wrap up that report this week. So what I suspect may happen, we'll use this distribution list for Bill and DSS to invite this group back to respond as a stakeholder group to the DSS proposed model that they'd like to hear from folks about. So I think they probably will do more than one stakeholder group. Okay, thanks, Jeff. So anyway, that's where we're at this point. So I'll turn it back to you, Jeff.
Sure. I was just texting or chatting with Tim that Bill is going to join us at 9:30, probably not to talk about the Connecticut model, but he will be joining us at 9:30. We can maybe give him the floor for a few minutes and he can update you on progress at DSS on that. Okay, so that kind of brings us to the agenda item on looking at our work group recommendation reports. I did put a few slides together just to help guide our conversation and distill some of the information from the report. So hopefully you all can see that. So first of all, I won't go through the goals. We just talked about those, but we did have a number of presentations from within the state, particularly the 1115 waiver and the Integrated Care for Kids initiative, who we've been partnering with throughout this work group, and are working on a demonstration project in the New Haven area that includes an alternative payment component. And we also, a month or so ago, had presentations from 3 other state models in Pennsylvania, Oregon, and New York. And we learned a lot from their approaches that they're taking in those states. From an early meeting, we identified that our major components of building an APM needs to cover at minimum the things on the list towards the bottom there. Clearly identified goals, a target population, or perhaps multiple target populations, strategies, clinical strategies and otherwise, as well as payment strategies, technical assistance that can be offered to providers as in a glide path kind of an approach, And then, of course, the outcomes and metrics that underlie calculation of payments and success in an APM. I do think Tim said this earlier as well, but I think it's important to note that we remain in Connecticut in learning mode. We have a couple of good examples of this rolling out in the state, but we still have a lot to learn in this area. And I think opportunities to continue talking with other states and learning from their experiences so that we can, and also from national examples so that we can kind of pick up on lessons learned and avoid mistakes that other states have made. So as Tim mentioned, we want to have good guidance on future development rather than a fully articulated APM that covers all of these things. So when it comes to goals, these are some of the things that came up in the group and that are reflected in the report. We felt that it was important that goals incentivize health equity and disparity reduction as just a critically important area of work and all, and I think an imperative in healthcare in general. We also talked in this group that we want to ensure we have family consumer participation in determining goals so that their goals are relevant to the populations being served. And then with all that being in mind, here are a few more specific ideas with goals that follow here. Primary care behavioral health integration, which has been a pretty common area or goal or approach in APM that involves behavioral health. It's often included primary care behavioral health integration. Increasing access, use of evidence-based treatments, increasing treatment utilization, engagement, and completion rates. There was also discussion in our group about integration across levels of care that incorporate hospital and community providers, and then focusing on particular system challenges that we've talked a lot about in this group and other groups around emergency department use, inpatient readmission rates, the need to ensure better follow-up and connection to care rates coming out of certain levels of care, and reducing readmissions. We also talked about how APMs could be used to increase continuity of care with single providers, because one of the challenges in our community is that clients will sometimes move from one provider to another and back again as they engage in different levels of care. And then we also talked about engaging schools as well as thinking about at least behavioral health care and how it may integrate with social determinants of health, as sometimes APMs are used to pay for services that are difficult to pay for under traditional fee-for-service models. So I'll pause there. Any comments about the goal section?
I'll just add one comment for everybody. Not everybody on this group. I think there's a handful that we saw that were crossover from this work group to the data integration. But there was some crossover, particularly data that might be generated from any APM. Again, like the series of accountability areas, the ED rates and stuff like that, that also would be system level measures on how well the whole system is doing. And so I just call attention to that we're also hope to finalize the data integration work group report also. So we'll send that out. I think Jeff will send all three reports to all three work groups, just so we have the largest distribution list as possible. So anyway, I think just calling attention to that. So any comments on this from anybody?
I have a comment. Can you hear me?
Go ahead. Yeah, we can hear you.
Yeah. I just wondered about, this increased continuing care with a single provider. I just was trying to imagine how that's envisioned when many providers don't have all levels of care. Does that make sense?
Yeah, it does make sense. It does make sense. I'd invite anybody in the work group who remembers that part of the conversation well. I think Frank, but I could be singling Frank out inappropriately here, but go ahead, Tim.
Well, I was good. That was my suggestion, but clearly within a level of care, because we hear that within one level of care, often the changes in providers, LCSWs, clinicians every couple of years or less.
So it's really it's more of a kind of a workforce idea, Frank. Is that fair? Okay, got it. We'll make that change to make that more clear, because I wasn't clear on that point, and I don't think it's particularly clear in the report either. Thanks for that.
Well, there's a generic continuity to care about, whose responsibility is it to be sure that kids and families don't fall between the cracks if they're in between levels of care, or so the attribution components of that could be one area. The other part I think that we have heard in a couple of the state models was, I'm thinking about the provider who joined us from Pennsylvania, who basically said, before the APM model existed, they had a couple of levels of care. And the way that they structured their APM model was it allowed them to offer 4 or 5 different levels of care under that APM model. So they actually were able to be more responsive to the needs of kids that they were working with. So the example I think he used was, they had clinic-based, they had school-based, they had home-based, and they were all kind of separate levels of care, if you will. And the APM model allowed them to give whatever that one family needed at any particular time. So they could actually show up at the school, they could actually show up at the school under that one. So it allowed for flexibility to better meet need that was being determined, rather than leaving one level of care and entering into another. So in real time, it's just much more fluid. So I think that as a general concept was also part of that continuity to care component.
Tammy?
I really apologize if this is like completely misinformed, because I have not been one of those people who has been with the group since the beginning. But as I look at this list, I mean, just my initial kind of reflection or reaction, while kind of on an input or process side, all of these considerations like make a lot of sense. And I don't know if it needs to be more explicit, but like you would imagine that the goal is, like ideally a very specific health outcome. And so there are some kind of outcomes, kind of referenced in the integration bullet. I don't know if that's 4 or 5, but really, I think when we're thinking about goals, we're probably thinking about client health outcome goals, rather. I know that there are these kind of quality or process measures that are important, but in the end, what matters is how well people are doing. So I just think if it's not explicit somewhere, it should be.
Good point. Good point. Yeah. So I think we certainly have some representation of process in some higher level system related goals. If you're in the data integration group meeting, you'll recognize some of those metrics are common in a system outcome category of our data integration group. But you're right. I think there is space here to talk about health related outcomes for individuals and families, and to make sure that that's reflected in. So we'll make that addition. Thank you. Heather.
Yeah, just a comment, I guess, and I'm not sure it's about this particular list, because I understand this list to be the goals set out in the beginning of the process related to the work we were doing and the hearing the presentations, as opposed to the final outcome that we hope to achieve with the individuals we're serving. But the only thing I find confusing about this and the report itself is that it feels to me that this was started as a result of work with children and families. And yet it sort of puts feelers into adult services as well, and references a number of things that are really adult system related. Now, I know that adults are parents, so there is a relationship, but I think it's important to clarify, is this supposed to be about the entire system of care or very specific to children and families? Because all the language throughout the report is really related to children and families, but then it references other areas. And I would just urge us to be very clear about what we are trying to tackle here, given the immensity of anything that shifts payment systems to a different model.
Heather, can you give a couple examples? Because I think we didn't approach it through that lens. So I'm just wondering if there was something that we wrote through the lens of children and family that you're hearing through an adult lens. So just trying to grasp that.
I'm hearing the part that that references, and these again are references, which may just need to be cleaned up a little bit in terms of the language. 1115 waiver process, that is really about adult substance use services, both outpatient as well as residential levels of care. CCBHC is predominantly an adult model of care, although it also does incorporate all ages. And those are both very significant efforts that will primarily impact adult service system delivery as opposed to the child system. It will affect families in some cases, but not predominantly. So that's what I think. We just need to scan this and be clear, what are we talking about? Because if we were tackling this work from the perspective of the entire system, we also probably would have wanted to pull in other experts and presentations on what's happening around the country with adult service systems. And even in Connecticut, looking at the LMHA system, looking at the evolution of other services.
So I'd like to respond to that because I was very involved on the DCF side of the 1115 waiver process. And so it did in fact predominantly impact and does, and you know, because your services are so impacted, the adult residential substance use system. However, there was only one adolescent residential facility, and it does extend into, the requirement does extend into the outpatient arena. And once it entered into the outpatient arena, it wasn't just the adult, it was the child also. And what the connection that we were making was the DSS desire to, if we're going to upgrade the outpatient arena on the substance use side, we probably don't want to ignore the mental health side of the outpatient arena. So I think the bigger point in general in those two things, we were just pointing to that alternative payment models of a variety are in Connecticut and are coming based on more than one project. So I think that's bottom line, is that there are more examples. And so our desire wasn't to suggest that there are parts of adult-based models that would influence children, but rather there are examples where kind of the system, the financing system is shifting under us, regardless of whether we're doing it kind of in a more thoughtful, planful way, or whether there's these activities that come into Connecticut because somebody's won an award and that model requires them to do some things that shift the way they're paid. And then on the CCBHC, I would agree. I actually kind of just immersed myself with that, those requirements again recently, just to become more familiar with them. And clearly it's an adult-based model, but it also calls for, again, quite a bit of responsiveness to kids in the family system. So I don't think we were intending, but Jeff, I think we could take a look at that with Heather's recommendations, and just to make sure that we're not
I think
more
it's
clear.
I think it may be a fairly easy fix of just making sure that it's clear that we're referring to certain principles of APM in those examples, but that there would be a need to ensure that any examples that are any lessons learned or examples out of those primarily adult-based initiatives would need to be clearly applied to child and family populations or something along those lines, just so that we're being absolutely clear about we're referencing these because they're just examples, not because they're child-related examples, and can't just be lifted up and plopped down into a child system, to your point. Let's go to Cheryl, and then we'll go to Tanya.
Hi, good morning. I just, going back to the previous slide, there reference to one of the objectives being to integrate primary care with behavioral health more. I think that's certainly a lofty ambition, and it's sort of mom and apple pie, like who would argue against that? I just want to make sure that we're being very pragmatic about it, given the supply of behavioral health providers compared to primary care providers. You know, Connecticut Children's has been working really closely with the Village for Families and Children to integrate behavioral health. And there are just, you know, multiple complexities related to that. But it's really the supply issue that concerns me more than anything, because I think it's really easy for folks to support that goal. As I said, it makes 100% sense. It just needs to be grounded in some sort of analysis of, you know, what is the capacity to do so in the state of Connecticut.
So Cheryl, let me press you a little bit more for details on that. So when you're referring to supply, are you talking about strictly just around workforce in one
Correct.
group or the other, or probably, I would imagine probably both, because I know primary care has been there's a shortage of primary care physicians, as well as obviously a shortage of behavioral health clinicians right now.
Yeah, and I think I would focus more on the latter, behavioral health. We have over 200 primary care providers just in the care network, and I know Pro Health has just as many. So if you think about the number of primary care physicians out there, and I don't have a number on the number of behavioral health clinicians in the state, but my experience has been incredibly difficult to find folks that are focused on pediatric behavioral health, as evidenced by, you know, the crisis that we're seeing with emergency room use throughout the state. And so I just, again, I think it's really critical. And no one's going to argue with it. I just want to make sure that, you know, we're not setting ourselves up for a goal that's unrealizable.
Yeah, good point. And I think these examples are things that could represent goals of an APM approach, not necessarily things that absolutely will or need to, and certainly not all of these things at once. But excellent points. And you know, I think across every work group, one of the common themes that we sort of undergird in many ways anything that we've talked about in any one of the work groups comes back to funding and rates, as well as, you know, direct investments in supporting the pipeline, but also the retention of a well-trained behavioral health workforce. And then, you know, identifying a goal of or a potential goal of primary care behavioral health integration is one thing, but completely understand the enormous complexity of actually pulling that off in practice, which is beyond the scope of this particular report, but certainly something that if you were to go down that road, you would have to, that's a very extensive initiative in and of itself. So I appreciate those points. Let's go to Tanya, and then we'll go to Frank.
So I want to loop back to those initial goals as well, and kind of respond to like Tim's vision of single provider, because I agree with you. I think it's important for children and families to have like essentially a warm handoff of supportive transition, not just a drop you and move on. I think that impacts communication lines between providers as well as the system. So I wonder if that could be reflected a little bit differently around continuum care, you know, and it goes back to, for me, just more in trauma-informed practices where, you know, clinical level case managers are actually supporting the process within one agency to a next. So I get a little concerned about the single provider thing, just because the mid-level agencies that don't have larger systems are going to be left out. So, you know, if we don't have some of the levels of care existing, that kind of eliminates some of the smaller agencies. Does that make sense? Or
Yeah,
smaller
that's a good
providers.
point. Yeah,
Even
so
like,
I think,
you know, I didn't know if even private practitioners are going to be included in this this rollout. So that it just, you know, I think it's important, and I do see private practitioners dropping kids, you know, and for the, you know, the agencies kind of pick those kids up, but, you know.
right. So we can maybe expand a bit on that bullet in the report and make sure that we're referring broadly to the goal of continuity of care, whether that takes the form of within a single provider or continuing with a particular clinician within a level of care, or even across programs. But I think to your point, the importance of care management and care coordination as ways to support continuity of care in a variety of forms, I think could be a way to kind of address your concerns. Let's go to Frank and then Heather.
Just a further comment on integrating behavioral health into primary care and linking that to workforce. You know, there are models to integrate, as we know, and the collaborative care model is not reimbursed in the state of Connecticut by Medicaid, at least to the best of my knowledge. And so the mechanisms for bringing primary care into other, or bring behavioral health into, you know, traditional primary care settings, it's an added expense. I know there's a lot of work happening to have more integrated systems, but to me, it gets back to also just reimbursement. I mean, economists are now calling 2022 the year of the worker. And I think we have to come to this new reality. This, you know, a lot of these ideas were developed from the, you know, Children's Behavioral Health Plan as a result of Sandy Hook, but, you know, we're nearly 2 years in, you know, we've nearly completed 2 years of the pandemic. There's a new reality with regard to workforce that we have to address. And I do think it's tied to reimbursement.
All right, thank you for that. You're absolutely right. Heather?
Quick comments in terms of the continuity of care with a single provider. It may be more accurate to just say develop a goal there related to sustaining a capable workforce, or something related to, I mean, hearing the conversation, it's really about being able to hire staff and keep them so that the people we're serving aren't constantly changing clinicians within an individual provider. If it is in fact about continuity of care across providers, I absolutely agree that needs to be addressed through care coordination and protocols related to that. A statement about a single provider is a major system change if the intent is actually most services being provided by one provider. My other comment is under primary care and behavioral health care integration. This has to work both ways. The focus in Connecticut has been almost exclusively on behavioral health going into primary care settings and enhancing the access within primary care settings, not bringing primary care into behavioral health settings, which is critical for some of the folks we are serving who have high needs and don't necessarily get their primary care needs met through traditional primary care providers, including FQHCs, given the reimbursement structures.
Okay, good point. Any other comments on goals? We can move to the next slide. Okay, so we also talked a bit about target population, although I would say that in the work group discussions, we didn't get too far on this. We did see some examples of what other states are doing, how they selected target populations. So we really, with much of what we have on this section of the report is conceptual in nature, as opposed to offering up some potential target populations. So that's something that if the work group has any further comments on that, we could entertain that today. But we talked about both universal approaches, so primary prevention or health promotion strategies that increase the health of entire populations, as well as targeted approaches that address the needs of particular groups of children and their families. We once again talked about how the target population selection should reflect our overarching goals in our system around reducing health disparities and increasing equity. And then we also did kind of a crossover to our data integration group again, where we lifted up the examples of P20 Win and 500 Familiar Faces. And that educated us around the idea that you can mine the data that you have to identify high need individuals, high cost individuals, kids or families that are using emergency department or at high risk of inpatient hospitalization or other kind of system outcomes. And then you can target interventions around those high need, high cost families in a way as a one strategy for an APM approach. Sorry, I keep brushing my mouse and it's flipping through slides, so I apologize for that. So any further comments? Again, this is a place where if you have other ideas around particularly high need target populations that could be the focus of an APM strategy, we'd love to hear your thoughts on that. Tanya, go ahead.
So I want to kind of go back to Heather's comment about integrating how children are different than adults. And one of the core areas that we continue to struggle with is this, like, how do you integrate the engagement with the parent or caregiver population with this? And I don't know, because a lot of the high flyers or, the spaces that are familiar, they're challenged, often combined with other factors that impact the caregiver. So I don't know, I know that's tricky to talk about, but I know that's the reality of the functioning of the system is the caregivers are challenged either by mental health or other factors that impact care.
Yeah, great point. So I'm hearing, just to think about and consider two generational approaches in your target population selection, given that, many high need youth also have parents and caregivers with high needs as well. Very good point. Tim, you're off mute. Did you want to say something?
Well, I was just going to, it kind of ties into a number of comments around what I think is often kind of the attribution components of alternative payment methodology. And again, being sure that somebody is responsible to be sure that kids don't fall between the cracks, and that also is still reflective of parent choice. So that I think a comment was made, I don't believe there was any intent to assume that the same child might be exclusively served by one organization, for example, but there would be one organization to be sure that as the child changed from one service, one level of care to another, regardless of the provider, regardless of the continuity, is that the continuity is held by somebody, that somebody's responsibility to be sure that the child is followed out at a discharge of an ED or an inpatient and making sure they're getting linked, et cetera, et cetera. So I think, and how it's connected to this point again is kind of around that care coordination kind of model of practice where the identified patient, if you will, is potentially the child, but that it's a family intervention. I mean, you can't ignore the needs of siblings, caregivers, et cetera. So again, it doesn't necessarily mean that it's the responsibility of the person engaged in the level of care activity at that moment.
Any other comments? Okay. All right, let's keep moving. We talked about a section here on risk categories, which is essentially kind of the way that you structure your payment approach and the kind of risk attribution process that you select. The work group really was very clear about wanting initial risk categorization or the initial APM approach at rollout to focus on provider upside risk only, and then to rely on system and provider network capacity to fully implement APM. And the group was also really clear that the incorporation of downside risk should be considered after several years. And I think what we saw in our presentations from other states is that this was a very, very common strategy, that the initial rollout of APMs includes upside risk only and downside risk is only considered later down the line, and only when it's clear that the system has the capacity. And perception of readiness can be guided by both provider readiness factors, but also readiness from the perspectives of payers as well as parents and consumers of services. So we listed a number of risk category or APM approaches down below in those bullets, and kind of in increasing order of complexity, if you will. And, you know, without any specific guidance around which approach should be taken and at what time, just the notion being that, you know, start small, learn lessons from your early experiences, and then layer on complexity as time goes on, guided by readiness across the system. Any questions or comments about this section?
Yeah, Jeff, I had a question. Since we're not reviewing the actual report sort of section by section, is this the part that is at the end of the report where it goes into recommendations?
No.
So yeah, so you have the email, you did have the report emailed to you, and I understand if you didn't have a chance to look it over. This section it kind of follows in order in the body of the narrative of the report. So in the narrative of the report, it goes through the goals, target population, and then describes these risk categories. And then,
Right.
and then at the end of the report, we get into the recommendations. So I do have a recommendation slide at the end of this, and we're going to get there eventually. And if
Okay.
so, if you want to, if you can either comment on this now, or you can wait till we get to recommendations, it's up to you.
Okay, so no, I was just wondering, I read the report and I was just wondering if we were at the end of your presentation as far as recommendations. So my only comment is that I would not personally support including full risk capitation models as an option at all. I think the other options are certainly worth considering and looking at in the context of Connecticut service system. I know this is exactly the approach that's being taken in the work on the primary care side. I've been on the practice transformation task force and also the current task force related to transformation of primary care. And these are all the same models that are being looked at. The only one that I would not support including as a recommend, that's what I'm trying to remember, whether the full risk capitation was in the recommendation section or just one of the things being considered. So
right. Yep. Good question. And there is not a recommendation that states that we should be specifically targeting full risk capitation models in this approach. So that's not it, kind of in the body of the recommendations. But we're going to get there. So if there aren't questions, I mean, we're at 9, just kind of doing a quick time check. We're at 9:40. And if people are okay with it, we can just fast forward here to the recommendation section and just get your viewpoints on that. And then leave ourselves a little bit of time at the end for Tim to walk us through next steps. So if everybody's okay with that.
Also, Jeff,
ahead.
Bill did join us, so we want to give him a few minutes also just to briefly maybe talk about the opportunity for this as a group, as a stakeholder.
Yeah. Bill, while I go through the slides, you want to come off of mute and just kind of address that?
Yeah, sorry for joining late. I did want to just, confirm that this could be a good group, as I know there's other groups, there's lots of meetings, but potentially a good group to get some feedback as we develop out an APM really for the entire behavioral health system. I know that we're talking in different avenues related to the child, the adult, SUD, mental health, but I think we want to stand up an APM. It may not be identical for children versus adults, but maybe different measures, anyway, it might be different, but we thought that we would want to use at least this group and maybe some other meetings, subcommittees to pressure test our thinking around APMs going forward in the Medicaid space.
And Bill, do you have a time frame that might occur? We originally thought we might hear from you today, but obviously we got that pushed. And are you thinking that you'll have that, or DSS will have that within say after the holidays, or?
Yeah, I think we're trying to get our heads around a couple of different models where, just to give you a little bit of framework. So we're relooking at the certified community behavioral health clinic model, not necessarily payment model, but there are a lot of good qualities of the CCBHC model that we like. And so we're looking at that again very carefully. And then we got some feedback from, I think, New Jersey, Tim, about what care coordination might look like on the kids side. And that's where I said it may not be identical in terms of kids versus adults in how we stand up what we would see as incorporating meaningful care coordination into the system that would allow providers to, do meaningful care coordination and achieve those outcomes that we all want for kids and adults.
Thank you. There were some earlier comments that you did miss that in particular around the 1115 and the CCBHC model being more primarily an adult model than a child model. So just wanted you to be aware of those comments. And then, so what we're jumping ahead because we didn't finish the recommendation parts, but before this meeting ends, we'll talk about we're still hopeful that this group winds up this with our last meeting. We finish out this report with this last discussion around these recommendations, and we'll get it out to everybody again. But we would then kind of re-engage, but not as a continuation of this group, but as an opportunity for that stakeholder feedback to DSS. So
Yeah.
it makes sense.
So,
Okay,
right. Yep.
great. Thanks.
All right, thanks, Bill, and thanks, Tim. So we've got 3 hands up. So let's go to Tammy first, and then Frank, and then Heather.
Thanks for sharing that, Bill. I agree to some extent that this group can be part of your kind of testing or vetting of your proposal around the Inc. APM, but I just wanted to follow up on your comment about CCBHC being kind of a model worth looking at, but not the money or not the payment model. So I was just wondering if you could expound about that a little bit. What about CCBHC do you think is useful, and what precludes tying that to payment?
Well, let me just clarify. If we went down that road, there would certainly have to be payment reform. So I'm not saying that there would not have to be significant payment reform, but replicating a PPS rate system is probably not something that we would pursue, but we would definitely, I am acknowledging that whatever model, whether it's CCBHC or any APM, that I'm looking at recommendation number 1, we're acknowledging that we have to take a very hard look at the payment model for it to work. So I just think all I was saying is that we're not necessarily tied to the replicating the FQHC payment model if we pursued a CCBHC model. But definitely acknowledging that payment reform would be a component part of it.
All right, Frank.
Thank you, Bill. And I'm glad we're looking at models in other states. It caught my attention when you mentioned New Jersey. I practiced there some 20 years ago. And, just to keep in mind a big difference on the child side in New Jersey, but also on the adult side, and compared to the adult side in Connecticut as well, is that New Jersey has a, I'd say a much more functional county level government system, and many of the services are very county-based and a lot more local control, which when I went there, I found a little bit confusing, but grew to like, and it helped to coordinate services. As you know, Bill, on the adult side, I know we have our regions on the adult side and the regions with DCF as well, but I could say it's not nearly as functional as it is with a strong county-based system. And I think it's part of the reason why things are working. New Jersey was implementing things along the lines of what we're talking about some 20 years ago. And I would hope that there'd be similar coordination on the adult adult side.
Agreed.
Heather?
Yeah, I mean, I think Bill's comments are precisely why I made my comments earlier about we got to be clear what we're working on. Are we working on an entire system design, children, adults, mental health, substance use treatment, et cetera, because there are very different systems in place in Connecticut. There is an adult system that actually exists under the LMHA system. The CCBHC grant money has augmented that. It's also created some issues related to how that money's been awarded and how it's being implemented. And then it creates a cliff on the other side of it if the money stops flowing and providers have built programs that can't be sustained. But it's a very, very different system. The child system is not organized in the same way. There are a lot of services in the child system, but they're not coordinated in the same way. So I just would urge us, if we're going to launch into this work, which I think is critical to do, that we're at least clear what we're doing and who needs to be involved in the process, because this group has been largely driven by discussions about child and family related service systems, not about an entire age range service system. And yet it keeps working its way into the conversation. So I would just say, let's just decide, what are we going to work on and what's the scope of that? And then we need to make sure the right people are at the table. The other comment I just want to make is on recommendation number 5. I think we need to add there that data collection efforts need to be funded. Over and over again, as providers, we are asked to change how we submit data, where we submit it, how we use it. And there is rarely, if ever, any reimbursement associated with the costs that we incur as providers to comply with new state mandates and reporting requirements. So if there's any way to include something, I think the language here about reporting burden is a little lightweight when it comes to what we all deal with all the time.
Yeah, I think we can address that by tying that to the ideas around assessing readiness before you layer on additional elements of an APM. And I think part of what you're referring to is in the area of provider readiness would include the necessary infrastructure, which includes data and probably other things as well, to be able to implement additional steps of an APM, which particularly anything that relies on metrics. So yeah, to your point, we can make a connection there between the notion of data infrastructure and funding as it relates to assessing readiness over time. If I see your head nodding, so I think it looks like that might work as a solution.
I just want to make one point of clarification. Sorry, Mark, just 1 second here. So again, just to be clear about this group, we did articulate it earlier, and that these group recommendations are the generic components, and these are some of the recommendations that we're commenting on now, but this is a work group for the Children's Behavioral Health Implementation Plan Advisory Group. And this report is going to the 12 commissioners of that body, and that body. So just reiterating that, we also added the opportunity, thinking it might be ready today, but it wasn't, to have DSS utilize this group as one of a variety of potential stakeholder groups, I think, as Bill referenced. So your broader point, Heather, I think is still well taken, but this body is focused on the children's side. And then as DSS goes forth with this body to just use this kind of distribution list as one stakeholder group, I'm sure there will be other road stops there. Bill, you can speak to that. And then there'll probably be opportunities for the adult system stakeholder group kind of folks to weigh in also. So I think those points that you've made here, Heather, I just want to be sure that our goal here was clearly on the children and family side. So thank you for that comment.
All right, let's go to Mark Schaefer.
Can folks hear me okay?
Yep.
Good. So I recognize that the purpose of this group is not primarily about data. There's another group for that. But as a follow-on to Heather's comment, I'm reminded about about the importance of access to data by the providers who are accountable for achieving the outcomes. I think Bill may recall the implementation of PCMH Plus as an example, where the data, you had basically ACO type entities, PCMH Plus entities that were accountable for cost of care and achieving certain outcomes, but they didn't actually receive in the first years of the project raw data that would enable them to basically to implement analytics that would allow them to inform their ongoing improvement strategy. And so I can't emphasize enough the importance of not having some third party designated as the entity for producing reports and data sort of in a standardized way across providers, but rather to recognize that data analytic innovations is part of the service delivery reform, care delivery improvement process, and that raw data should be made available to the providers who are accountable commensurate with the start of the APM, so that they can, so that they're in ability to drive improvement from the earliest days.
Thank you for that clarification, Mark. That's a great point. We'll make sure that that's included in the final.
I just want to say I agree with that. So whatever measures that we're using to define success, I think what we would want to try to do is provide baseline data to the degree that we have it out to those providers participating in the APM model. So you'd have your baseline data for your attributed population, so you could see how you're doing on the measures. You know exactly what the measures are, and you could start putting in putting in strategies to improve those measures immediately.
And I think that there are ways that we can flesh out the concepts around, certainly around data infrastructure at the earliest point possible at the outset of a rollout of an APM, but also speak to the need that you just described with respect to the provider technical assistance component as well. So we'll incorporate that in. Any other comments on recommendations? We're getting close to time. It is 9:57. Tim, maybe I could offer up that if people have other comments that they wanted to offer and didn't have an opportunity to today, just go ahead and email myself or Tim, and we'll make sure that we take a look at that and incorporate. And with that, let me just turn it over to Tim to wrap up and talk about a couple of next steps. Tim, you're on mute.
Apologies. Yes, our goal was to finalize all three of the work group reports to our leadership from all the commissioners and to the Behavioral Health Implementation Advisory Board for Children by mid-December. So this is that week. This may take us a little bit into the next week, but we really do want to finalize this report electronically and resist coming back for another meeting. So we'll ask you to make your final recommendations to us following this meeting as rapidly as possible. We'll get another draft out, and then we'll go from there to finalize. So we do appreciate the consistent attendance to this group. Many of you participated in other work groups, so we appreciated your involvement both here and elsewhere. There is a planning to come together in a kind of a broader group to just, I'm not sure if it's going to be monthly or what the cadence will be, but to just be sure that there's some kind of meeting structure where there's a update or reporting out on all of the different activities that came forward as a group of recommendations. I think these next couple of weeks will become critical, not only for children, but also on the adult side for the mental health system in general. And as we continue to see challenges across the state, the EDs, and again, particularly related to children, but I also understand it's happening with the adult side too. So these are significant times. So I think we do want to be sure we have space to come together that there is both community, stakeholder opportunity, families, providers who can meet with and hear from state government leadership in a variety of settings about what's happening and what's going on. So stay tuned. A universal announcement will go out to all of the participants, to all the work groups, including the short-term work group, which was the kind of the fourth group that participated in many of these. We'll finalize those results and we'll keep everybody posted as best we can through that structure. Stay tuned. We'll assist Bill and DSS in getting invitations out to this group for an opportunity to offer DSS some feedback on the APM model that they're going to start to put forward for stakeholder feedback. So I'll end it there, and we appreciate you all again. And whatever holiday season you celebrate, we wish you a happy holidays, and thank you again for all your participation.
Thank you, everybody.